MRD just means minimal residual disease. So, I showed that slide with that iceberg. It's really like, can we see the bottom of the floor where we got no myeloma cells? So as our technology improves, when we say someone's in remission, that's using certain criteria. MRD is a more sensitive way to look to see if, we can still see disease. And if we can see some using whichever assay you're going to use, that means there's still some stuff there. And if you don't see it, it means you're just closer to the floor. At least that's how I interpret it.
MRD negativity, as he suggested, decrease is you have a very low number of myeloma cells in your body. You're not cancer-free, but we can't detect it usually on a bone marrow biopsy. We don't yet know how to deal with that data. Most of the time, if you have somebody who's MRD negative or MRD positive, I'm not sure exactly how to react to that information. Sometimes I'm making deals with patients, right? They're on Revlimid, having diarrhea all the time, they hate paying for it, they hate me, and then we do a bone marrow biopsy, try to figure out what to do with them because we have a monoclonal protein which is negative, their light chains are perfect, and they're sick of being on maintenance. So we do a bone marrow biopsy and we find they're MRD negative, and we've already discussed between the patient and I, okay, if you're MRD negative, we're not going to do any further therapy. Or if you're MRD positive, we'll continue to try to use the Revlimid but do different things to decrease symptoms. So that's one way people can use MRD status to figure out what to do. Clinical trials are ongoing to incorporate MRD status as a way of deciding how to act in the future, but those are, to my knowledge, some of the more definitive ones are years away from reading out exactly how to use MRD status in clinical practice.
Yeah, so I think that MRD is not a concept that's exclusive to myeloma. It's used in a bunch of other diseases. So really the first way that it was used in a very useful way was actually in kids with leukemia. So in kids with leukemia, many of them are cured, but not all of them are cured, and you can give different levels of chemotherapy. And so one of the best uses in kids is if you give chemo, and then you test for MRD, and if it's positive, then the chemo that you're giving them is probably not working, and so you either give more chemo or you take them to a transplant. If they're negative, like you've eliminated as much as you can eliminate after the first round of chemo and they're MRD negative, then you just get more standard chemotherapy. So that's really I think, prime, that is the best example of how to use it, because you're using the test, you're getting the test, and then you're using it to make a decision. Mm-hmm. So what we don't know in myeloma is that, MRD is really defined by the test. So if we were doing MRD based upon light chains, right, then if your light chain level is a certain amount, that's as much as we can measure. So this allows us to measure much smaller amounts of myeloma. But as Craig was saying, we don't have any trial where we say, we're going to do something, we're going to test, and then if we get a certain result, we're either going to do this, A or B. And so we don't have that data yet, so we're guessing as to what might come of that, but we don't really have those data yet. So it's one of these things where oftentimes in medicine, the technology outstrips the advice we can give to patients. And another way we do this is by sequencing all the genes, as I showed. And so it's something where it is very exciting technology, but it's something where I actually don't recommend it to a lot of patients because I don't know what to do with the result. So that's sort of where MRD is in my own mind.
There are different ways of looking at this. So one way is by taking a bone marrow sample and running it through a machine called a flow cytometer to try to find small little pieces of myeloma in the bone marrow. It's like looking for a needle in a haystack. Another way of doing it is actually each myeloma cell has like a DNA code on it, and we can and all the myeloma cells will have the same type of code, and we can try to see if we can find that piece of DNA that myeloma specifically is coded with in a population of cells, and whether we can see that or not.
Do you want?
Sure.
So,
So Xgeva is, the next thing available for myeloma bone disease, and it is an antibody that's effective. It puts potentially a slightly higher risk of osteonecrosis of the jaw, and beyond that, further treatments for myeloma bone disease are still in clinical trial, and to my knowledge, nothing is set to be approved in the next 18 months, so I don't see that. For treatment of osteonecrosis of the jaw, it's still very supportive, primarily chlorhexidine mouthwashes twice daily, and to try to minimize the activity of an oral surgeon. Most oral surgeons now know not to touch them and just to scrape off some of the sharp bone and do very little kind of excavation projects in your mouth. Less is more. Right now, Selinexor is approved for patients with multiply relapsed myeloma. Selinexor, like panobinostat or Feradac, are approved in the relapse state for patients with myeloma, usually in combination. And because alone, Selinexor, it provides some response, but after 4 and 5 lines of therapy, you're dealing with very difficult to treat myeloma, and you're doing everything you can. Selinexor is a cool drug because it works in a number of cancers in about the same proportion of patients through a new and novel mechanism. So it's super cool. So the mechanism is complex, and it's primarily intracellular, and it's shared amongst a number of cancers. And what's great about it is it's a new and novel mechanism. What sucks about it is it's really hard to tolerate. So you have a lot of nausea, you have a lot of fatigue. It's difficult to deal with that drug. There are newer supportive measures, intravenous antiemetics that are given every other week in combination with antiemetics like olanzapine or Zyprexa, which have been shown to decrease some of the side effects. But overall, it's an active drug, but it's hard to stay on it long term for the majority of patients.
there isn't for Selinexor. I think one of the things to touch on is that it is a difficult drug to give, to have people stay on. And I think that one of the things, so we're better at some things than other things. I think that like coming up with new ways of dealing with the disease, we're okay at. But I think that one of the things we're good at is actually, if you have medicines with side effects, to try and come up with strategies to deal with those side effects. I think we're actually not horrible at. And so for an example might be is if you get a medicine called daratumumab or Darzalex, it used to be that it was very difficult to give the first dose. A lot of people would have reactions to it, and so there have been ways developed where you have to take a lot more stuff beforehand, but it actually, I think, really decreases the number of patients that will get those reactions. And so one hopes that Selinexor, because it's such a novel thing, that maybe you can use it earlier, but if people really get sick from it, then it becomes hard to use in something like second line, right? Because there are other things you can use there that don't make people as sick. So I think that as time goes on, I'm hopeful that we can come up with better strategies to deal with the side effects of Selinexor, and then it'll be a lot easier to use. For some of the medicines, we've tried to do that and it hasn't worked. But for other ones, I think we've been successful at allowing those drugs to be used much more safely, and so that would be one hope with Selinexor.
That's a good question. So CAR T cells right now, they're being studied in patients who have had multiple lines of therapy, including transplant. Typically, we say if you've had induction, transplant, and maintenance, we call that your first line of therapy. So all that, even though that sounds like 3, it's still considered one. And then you got to do something else, and typically something else, before you become eligible for some of the CAR T trials that are out there and what we think will get approved. So that's probably going to change over time. There are also going to be clinical trials that will be available, because even with the CAR T, it's similar to the allo transplant. What we're seeing is people that didn't respond to anything else. There are some people who are responding to the CAR T, but it also is coming back in some people. So the factors why that happens is not clear yet. One of the reasons for the failure of the CAR T is, there's a flag on the myeloma cells, and we program these T cells to go get that flag. Well, the myeloma cells are sneaky, and they just sometimes shut that flag off. They're like, I don't want this. And then the T cell doesn't know what to do. It doesn't see the flag. It doesn't kill the myeloma cell, right? So that's one mechanism of resistance. Well, how do we prevent that? Well, there are clinical trials looking at, is there a compound that we can give that prevents the myeloma cell from, getting that flag, down? There are mechanisms intracellularly that we could target. Also, the environment inside the bone marrow sometimes is very toxic to these T cells, and the T cells get kind of told to just go hang out in a corner. So we might be able to manipulate the environment, but that involves other strategies, not just the CAR T, doing other things with the CAR T. So these are things that are being looked at, but they're all on clinical trial right now. So I'd encourage participation in trials. As far as the allo transplant, I think that's a very, I do allo transplants. I believe in that. I believe in that graft versus myeloma effect. And yet I counsel most patients that that's probably not something you should think about unless you've exhausted other options. And with all the options that are being discussed, there are lots of things to try before doing that. But you don't always have a donor. So there are things that you can definitely get lined up, look to see what the options are, and then have a careful conversation about that. We still do them, but it's much rarer nowadays. And there are still situations where I have patients who've gotten the allo transplant. They appear to be cured, but I also have a lot of patients that have gotten the allo transplant and it still came back. Now, it does seem like even when it comes back, it might be a little easier to control. So typically what I would say is if you're young, have high-risk cytogenetics, have seen a couple of lines of therapy, then that's a conversation to have with your physicians.
I missed the transplant talk. I'm sorry, I was out there. So I'm going to present a contrasting point of view. So I don't think there's a good candidate for a standard allogeneic transplant. There is no one who should get an standard allo transplant. On a clinical trial with newer novel mechanisms to increase the graft versus myeloma effect, I could sign up for that. I would think about that. But there's no way I would send any of my patients, no matter how young, how old, how high risk, how low risk, to a standard allo transplant. And to cap off the CAR T discussion, so the BB2121 vector from Celgene, originally from Bluebird, originally from the NIH, that should be reviewed likely in 2020 and has a chance for FDA approval. There are CAR T cells now. We've enrolled a number of patients nationally and in Atlanta, where I am, for patients who didn't get a very good partial response after their auto transplant, so they got a CAR T. We have a trial coming up, sponsored by Janssen, another one sponsored by Celgene, for newly diagnosed high-risk myeloma patients that have CAR T cell infusion as a portion or a component of their initial treatment. So we're seeing CAR Ts both upfront, second line, third line, at all line in the clinical trial setting.
So I actually at Hopkins did a lot of allo transplants for myeloma, but they were all done on clinical trials. So I think that I totally agree with Craig. I think that doing standard of care, what are called standard of care transplants, should all be autologous transplants. So it should all be stem cell transplants. I think that if you have a trial available, like the whole point of the process, right, is that if you don't really know what you're doing, we should learn something from it and figure out what we're doing. So I think that it's really important to do things on trials and to actually figure this out. Part of it is, do you make a point of having a trial that's available for that, right? So at Hopkins, we always had a trial that was available for allogeneic transplants for myeloma, because that's something we were interested in. That may not be at every single place, but I think that like one of the things is that, the three of us for sure don't agree on everything, and I think that that's part of how we figure things out, right? If we all agreed on stuff, then if there's a way to cure someone easily, we would definitely probably all agree on that. But I think it's this sort of exchange of trying to figure out, well, what is the best thing is really sort of why we're doing what we're doing. I think as far as CAR T-cell therapy goes, I think that it's super exciting because you can take patients who are really don't respond to many drugs and get them to go into remissions. I think that the challenge is that is keeping them in a remission. And that's an avenue for more research. Like, one thought is, well, do you do the therapy earlier on in the patient's course? You don't wait for them to relapse 5 times, so it might work better then. Do you add other drugs, as Arvin was saying? So I think there are a lot of possibilities. I think that once it gets approved, I'm hopeful that it really expands quickly. In the diseases where it's been approved, like there are 2 CAR T cells available now for leukemia and lymphoma. They are available, but I would say that they have not been fully utilized, and there are a number of reasons for that. They seem to be more dangerous in those diseases than they are in myeloma. People can get a lot sicker, but I think there's some lessons to learn from those products, and as we generate or we have available CAR T cells for myeloma, I'm hopeful that since we're not the first out of the gate, that I think we'll be in better shape because we learned from those other 2 experiences. I think that technology, it's all about how do you engineer the immune cells to sort of do what you want and to not do what you don't want. And so there are many strategies to do that, and one is that instead of doing allogeneic transplantations, you actually get T cells not from yourself. You don't take them out of you and manipulate them, but you get them from someone else, a healthy person, right? And what you can do is you can grow them up, expand them, and then what that does potentially cuts down the time that it takes for you to get CAR T cells. Maybe, so if we do 100 people, we make CAR T cells, it's going to be 100 different products, actually. They're very variable amongst people. So I think that's exciting. There's some strategies. There are trials going on in leukemia with allogeneic CAR T. I don't know of any in myeloma, actually. But, I think that the technology is there to do it.
There is one off the shelf that I'm aware of in myeloma, but like Dr. Matsui is saying, it's still early days.
And the first 3 patients to undergo, with a blood cancer, to undergo CRISPR-edited therapy, 2 patients, I think 2 patients with sarcoma, 1 patient with myeloma, or 1 patient with myeloma, 2 with sarcoma, I forget. But we're gonna hear data about that at the American Society of Hematology meeting next month. Right, I almost guarantee you I'm going to be different than my colleagues here. So I believe you should be on Zometa because of a large UK trial called the MRC9 that looked at Zometa and clodronate and was re-examined. It found that the benefits of Zometa were primarily in patients who had myeloma bone disease, and the benefits in comparison to the relatively ineffective oral bisphosphonate clodronate, the benefits were much larger in patients who didn't have a good response. And those patients who went into a complete remission, the benefit of Zometa was 0. So I encourage patients, because you don't know when you're starting treatment how it's going to go. You're just starting something new. So in general, on those patients with myeloma bone disease, I start Zometa or Xgeva if they have decreased kidney function. continue it monthly until I have good control of the disease, and then stop it, and try to decrease the amount of exposure to intravenous or subcu bisphosphonates as much as possible.
So I typically don't manage that portion, so I'll pass it on to Dr. Betts.
Sorry, Bill.
So I think that the standard line is you get it monthly for 2 years, and then you extend the interval after that. I think that, the original thought was that these things are benign, right? That there were actually very few side effects from it, and but I agree with Craig, actually. I don't like giving them forever. When people say, I've been on bisphosphonates on Zometa for 10 years, I'm like, wow, that's a lot of Zometa. And so I think that looking, the question is, what do you use to look for bone disease, right? And I think if you use pretty sensitive measures like MRI, PET scanning, I typically, I will start people out on it because you just never know when they get newly diagnosed. But if they don't have evidence of bone disease, I usually stop when I stop their induction. So if they go on to a transplant, I usually don't give it after the transplant if they don't have any bone disease. For those people who do have bone disease, I will give it longer. I'll give it more frequently, and then I'll space it out. But I tend to space it out to every 2 to 3 months pretty quickly because, if you're on maintenance, things are going well, the last thing you want to do is have to come in just for your Zometa. There's absolutely no definitive data what we should do, right? And I think that it's anyone's guess. The amazing thing about bisphosphonates is that they get into the bone, they prevent, the reabsorption of bone, so they prevent the excavators, but it's in there. It's in there, and it's hard to get it out. So I think that if you have this collection of layer after layer of Zometa, at some point it probably has maybe a little bit less effect than it did early on, is sort of my thought. But that is totally an opinion that's not backed up by a lot of data.
If your bone density is normal, we have no idea what to do with that information. So there's no data about DEXAs in myeloma and whether you should give a bisphosphonate, nothing. So whether your bone density is normal or not is irrelevant. The question is, does your myeloma affect your bones? Do you have a history of myeloma bone disease? That's what we currently are based on. To my knowledge, there's no useful information about a DEXA in myeloma. This is the old theory that, oh my gosh, I could have fourth line multiple refractory patient who's got smoldering myeloma, right? And so this theory on average hasn't yet borne out because the two precancerous conditions, which we've named horribly, one is called MGUS, monoclonal gammopathy of undetermined significance, and smoldering myeloma. These are precancerous conditions. They don't have evidence that these cells are trying to kill the patient. In myeloma, on average, there's CRAB criteria, which is clear biologic evidence that myeloma cells are trying to kill the patient. And then there's the so-called SLIM criteria, where there's greater than 60% plasma cells in the bone marrow, greater than 1 lesion or abnormality on MRI, and a high serum free light chain ratio. Those patients who meet the SLIM criteria have a greater than 75% chance of developing symptomatic myeloma from smoldering myeloma, which means that you're over-treating 25% of patients who don't go on to develop myeloma in 2 years. So there's always a balance. And in each one of these disease spots, from MGUS to smoldering to multiple myeloma, the risk of transition there is not 100% because you're estimating, you're using probabilities to determine the likelihood that somebody's going to develop symptoms. But unfortunately, the technology in breast cancer on average, prostate cancer, colon cancer, lung cancer, all those normal cancers where you get a biopsy and the pathologist calls the surgeon and says, it's cancer, you got to do something about it. Or calls the surgeon and says, it's not cancer, don't do anything. We don't have that. We get a bone marrow biopsy and the pathologist says, 9%. have a nice day. Click. That's all you get. You get a percentage of the plasma cells, but they don't tell you if these plasma cells are trying to harm the patient. It's still a clinical diagnosis, and we suffer in the myeloma world because our technology is not adequate to basically look at a plasma cell and figure out, is that a myeloma cell or is that a plasma cell? There's lots of tools that we're getting closer, but to my knowledge, we're not there yet.
So I think that, it is challenging because there are a bunch of different ways where people define risk. People say, well, I have high-risk smoldering myeloma. And I say, well, by what set of rules do you say you have high-risk smoldering myeloma? Because if you use another set of, another calculator, you might not be high risk. So if you take patients with smoldering myeloma, you look at a bunch of different, there are, I think, 3 in general pretty well used criteria. They don't always agree for a single patient. And so I think that, part of it is that treating someone early, right, is you're trying to prevent something, but you're treating someone who's asymptomatic. And I think that, usually not treating someone doesn't have a lot of side effects, right? And so for me, it's similar to the allo. I think that this is a time when we need to figure it out. And so I am more than willing, when I was at Hopkins, I was more than willing to put people on clinical trials with smoldering disease, and we did that a lot. And but in the absence of that, I think that I'm afraid of over-treating a lot of people, right? And so for me, my philosophy is if we can learn something from it, the patient's willing to undergo that, they know what the risks and benefits of doing that are, I'm more than happy to go ahead and start treating them on a trial. If someone shows up and says, look, I have high-risk smoldering myeloma, you can kind of tell they might want you to say, well, let's go ahead and treat you. I am I don't like doing that. I have never treated someone with smoldering disease who wasn't on a trial, personally. But there are like a lot of gray areas in it. Part of the benefit of that part of the disease is it tends to move a little bit slower. So you have time to help you, right? It's not like you see the patient once and you got to decide right there, you have smoldering disease, what are we going to do, right? You can usually check them a month later. You can check them 2 months later. And you can sort of get an idea of where things are going. So that's one thing I think that when we think about like how to approach this thing, I like using time as a way of helping me. Because if someone their M protein stays flat, it's 3 years later, then I say, good thing we didn't treat you 3 years ago. But I like using time, and I think that, I will admit, I've had times where I've checked someone's light chains every 2 weeks because they were so worried about it. But after about 3 months of doing this, they said, okay, we don't have to probably do that. So, like I said, I like to use time as part of it, but it is a little bit fuzzy. There are a lot of, differing opinions about what to do in this space. There are a lot of really great trials now, I think, that are available. And so, I'm hopeful that this gets answered at some point, because there are a lot of patients with smoldering myeloma.
So every trial that we're doing with myeloma, we're looking at endpoints, right? And so the treatments are so good right now that, the endpoint we're really looking at is this endpoint PFS. In overall survival, we are very rarely able to show any differences. So I would say yes, but if you waited 15 years, maybe there'd be a difference, but it might be so small that you have to wait that long to measure it. But even with these novel therapies, there's some data being presented at our annual Society of Hematology meeting. Even when you're combining 4 drugs together, you're getting tremendous response rates, things like we've never seen before. And in some of those trials, patients are being transplanted as well. And you can see in some situations, patients who get the transplant stay in remission longer compared to novel agents. Even though they look like they're in remission, you have to watch them longer. So I think it's a controversial area. Eventually, we might get some sort of test like this once we learn how to use MRD better. That there might be an MRD test that we say, okay, you're at this MRD level, you don't need a transplant, you're going to be fine, right? Versus, oh, well, you could really benefit from that. But right now, we have no idea. So the best way to answer this question is really participate in trials. And I think for now, we've heard this story before about moving away from high-dose melphalan, but the data is just not there yet.
And autologous stem cell transplantation has still been associated with the longest overall survivals. So those patients who have undergone it have, on average, lived longer, but what your oncologist was telling you was related to the most recent trial and trying to say the period of disease control is longer, but the most recent trial hasn't yet shown an overall survival difference. So we're still kind of in a data-free zone trying to figure out what to do. And on average, I think I would make the point that autologous stem cell transplantation is primarily targeted, like all our current FDA-approved treatments, towards patients with low-risk disease. Because we're not terrible at treating low-risk disease, but we still stink at high-risk disease. This is where all our area of growth and all our research focus is shifting towards. And autologous transplant, something that people think of as very invasive, it has a very long name, uses the word hematopoietic somewhere there. Gosh, that gets complicated, and they think that should only be in patients with high-risk disease. And in fact, it's actually better targeted for patients with low-risk disease who have good control of their myeloma with induction therapy. Those are the patients that really benefit from autologous transplant. Because whether you have low-risk disease, intermediate risk disease, or high-risk disease, you still have the same risk of side effects. None of that changes based on your myeloma. What changes is the value, which is the amount of the period of time of disease control after transplant. That's what changes between low risk, intermediate risk, and high risk disease. And so patients with low risk disease who are expected to have a long so-called value from transplant, that's very appealing, whereas those patients with high risk disease, not nearly so much.
So I think part of the issues like of transplants versus novel agents is that the novel agents are new, right? So that means that we haven't really figured out what their long-term benefits are. So really the data that if you look at sort of what is the benefit of doing a transplant in a stem cell transplant in a patient with myeloma, in terms of how long overall they live, is really studies that were done decades ago. When we didn't have novel agents, because those, if they were novel agents back then we would just say they're agents, right? So it ends up being that is a moving target. So in the study that Arvind showed, where you look and see the disease control rate, right, is different with an autologous transplant. There, most of the patients are all still alive. The majority of patients are still alive, so you can't tell whether one group is doing better than the other group. So if we wait, years, we'll be able to see whether there's a difference or not. But with the data that we have right now, we can surmise what the difference is in disease control, but we just haven't waited long enough. And then by the time we get those answers, there'll be CAR T and there'll be other new agents. Like we're always behind in that sort of regard, so it ends up being tough. There's certainly not as much, there's certainly almost no data there, right, that tells us sort of long-term effects of doing anything nutritionally or supplement-wise or activity-wise, or I think that my own approach is this, is that I want to know what my patients are on. I think that there's a possibility that some of the things that people will, let's say supplement-wise, will take can interfere with the drugs that they're on, right? That I want to know. I think that in the absence of that kind of thing going on, I try to be a common sense type person, and I say, look, okay, if you want to do that and it makes sense to you and I don't think it's going to hurt you, and I don't think it's going to interfere with the medicines I'm giving you, then I'm totally fine with that. Like, I can't give you an opinion because I'm not an expert in that area. But as long as, I think that it's not harmful, like I'm then as to the best of my abilities, I think that people should, be empowered to do other things that they want. For me, I say, look, I want you to be healthy, right? Myeloma is a chronic disease. I want you to be active, right? So I tell people, look, you got to get up, you got to exercise. You maybe have to do that a little bit more than if you didn't have myeloma, but I think it's important. I tell people, look, I want you to be healthy when you eat, right? Like I think that if you didn't have myeloma, it would be healthy to, have a good diet. So for me, a lot of it is, when people say, well, what other things can I do? I say, look, try to eliminate as much stress as you can from your life. Try to eat as well as you can. Try to get enough sleep. Try to do all the things that you would want to do if you didn't have the disease that would make you better. As far as supplements, other things go, like I said, my issue is just, look, I don't want to do something where I think it might hurt you, right? And I'll give an opinion that way. But I don't prescribe any of that. But they're like in Austin. Austin's a great place where you have a lot of stuff, maybe too much stuff. And I've had people call and say, look, what about this or that or whatever? And I say, look, just tell me what it is, and I can tell you whether I think it, I can give an opinion whether it's bad or not, but I can't tell you yes or no.
I just want some CBD oil I can afford. Man, I go running along this road today. I couldn't find any CBD I could afford. Sucked. So anyway, I'm in Georgia. So Georgia, a little bit like Texas, not known for being the thinnest and most fit state. And so on average, the things that I would tell you is that there's no supplement I'm really looking forward to. It's my wife is Indian, and Indians, they love to eat their way to health. If there's a supplement or a pill they can take to improve their life, they're going to eat that instead of doing anything else that's proven. I'm happy to do something that I can eat, and that will work for my cancer. And I try to emphasize to patients that they are the prey, and the predators come up at midnight to 2 to 3 a.m. These are clinical trials. It's proven to treat your cancer. Just send it 1995. If it includes a blender, for the love of God, don't do it. It's not going to help. Vitamix, they're never going to include a Vitamix. But anyway, literally, I've had patients go to Mexico to receive so-called stem cells intrathecally. They mortgaged their house and went to do that intravenously. Try not to do that. And the data, again, people don't realize, because GNC is a multi-billion-dollar company, and the supplement industry is multi-billion-dollar. They don't realize that there are no vitamins that have been proven to help humans, except some of the vitamins used for macular degeneration. That's it. No oral supplement has been shown to really help a human. So remember, you have to have a healthy skepticism about the weight of the trials that we've used in 1,000 different things, hoping that this supplement or that supplement will be the key, because we would love to have that key as well, be cheap, affordable, and potentially smokable. But never mind. Anything we could do to help, but the weight of the data is that most of the things we've tried have not been effective, and most of them actually have been harmful. Most vitamins that you have used in supplements have decreased overall survival in controlled settings in cancer. So that's the weight of the data. So you should start with that and then move forward in your supplement purchases. So there's not much agreement on that overall. Deletion of the small arm of chromosome 17p is the most common mutation in all of cancer. Seeing that in myeloma is never a good thing. At certain centers like ours, that means you get multi-drug maintenance to increase your chances of keeping your myeloma in control for longer. And at other centers, they don't do that.
So typically what I would say is push proteasome inhibition and also consider multi-agent maintenance therapy for something like that. But again, everybody's a little bit different, so always check with your physician.
Yeah, so I think post-transplant, it's, I just about, if the patient can tolerate it, I would give more than one drug as maintenance. But I think tolerability is still very important. I think that as Craig was saying earlier, I think that it's questionable whether or not, in some minds, whether or not you should do an autologous stem cell transplant in someone with P53 mutation, but I think that the jury, the data on that is not available. But I think that there are good, there's good data from Craig's institution about doing multi-drug maintenance, and I think that's places where I've been, that's really become the standard. So this is so I think that there are multiple approaches, right? One can say that, so in some diseases, what I used to tell people is that every drug is like, and most people, maybe people will remember this. So if you go to like Disney World or Disneyland, it used to be that you have to get a book of tickets, right? And every ride, you had to take a ticket out and give it to the person. So back when I was training, what we would tell people is with certain diseases is that every treatment was like a ticket. So you get a ticket, you give a ticket, and then once that ticket book was empty, then you didn't have any other treatment options. Nowadays, I think that it's a little bit different with novel agents, and I think that the idea of getting people under control is an important one. Like no matter what, if someone is sick when they get diagnosed, you got to fix that, right? And if it takes 1 drug, 2 drugs, 3 drugs, that's the primary goal of doing induction therapy. Once you get past that, I think that there are many options. You can go to maintenance, you can do a transplant. So I'm not necessarily, and there's some good data where, like if you, for example, gave someone Velcade at one point and then 3 lines later you try Velcade again, it may have some activity then. And so I think this idea is that once you're resistant to a drug, you're always going to be resistant to the drug doesn't necessarily hold. And so I think that we should use as many drugs as we think is necessary for that patient to get under control. I think that you got to think about if you're using more drugs or you're adding more toxicity, it's a balance, right? But I am less concerned with saying, okay, if we use all of these up, all of our tickets are gone and we're out. I think that doesn't necessarily hold with new agents. When you use a standard chemotherapy, that tends to happen. But with using novel agents, especially when you combine them, it's sort of like, that's where the magic happens in myeloma, right? So I think that using novel combinations or switching up combos is one way to get around that. So I like using multiple drugs up front. I think it gives you a better chance of getting the patient under control, getting their disease under control, and then you can open up options after that.
To my knowledge, none of the myeloma drugs are really toxic to the kidneys. So I wouldn't worry about the myeloma drugs being toxic to the kidneys directly. Although there's some theories and possibilities, none of that's really there. But the cancer itself, well, that's definitely toxic to the kidneys in at least 50% of patients. So control of the myeloma is very effective, is a big priority, and that is the way to preserve kidney function. None of the myeloma drugs currently are terribly toxic to the kidneys. So I think the best thing, so you're still allowed to use your head. So at 37 years, so I heard about this case. 37-year-old male comes in for back pain. Has an MRI done after being evaluated for horrible back pain for 6 months and has 3 compression fractures, 2 in the thoracic and 1 in the lumbar, and is shown to have very thin bones in the thoracic and lumbar vertebra. And what does the oncologist do? Does the oncologist do a bone marrow biopsy, a CT-guided biopsy of the vertebra, or does the oncologist say, this is osteoporosis, don't worry about it? Well, option C is what happened. And the oncologist said, oh, this is osteoporosis. The problem? It's a 37-year-old male with no past medical history. That is where it gets, you're allowed to use your head. Whereas the 85-year-old male who has the same presentation, it gets more complex because you'd have to realize that the risk of osteoporosis in men and women above age 80 is the same. So you can still have osteoporosis causing compression fractures because gravity is always pushing down on us. And so trying to differentiate is a very challenging thing because sometimes if you do an x-ray, you just see a compression fracture. But more in-depth cross-sectional imaging with MRIs and PET scans and adequate blood work is going to show an inflammatory picture and an infiltrative cancer picture in myeloma that you won't see in osteoporosis. If you can't do blood and you're just stuck with an x-ray, they can look the same. I'm sorry.
No, I think that I've not been in Austin for long. I don't really know how, the Austin medical world works necessarily. I think that when I was in Baltimore, I saw a lot of patients with MGUS who had osteoporosis. And I think part of it is it was regionally sort of built into people that if you had someone, no matter what their age was, if they had osteoporosis, that they would get an SPEP done. And so there, here, and I think my practice is a little bit weird, but I have not gotten a lot of MGUS consults, whereas at Hopkins, that was a lot of business, right? But that's because everyone, a neurologist would get a SPEP, a nephrologist would get an SPEP, an endocrinologist would get it, a rheumatologist would get it, everyone would get SPEPs. And I was like, oh my God, whoever's doing the SPEP has got to be a multi-millionaire because everyone is getting one of these things. So I think it just depends regionally a little bit on what the triggers are to sort of do more of a workup. But, just people are different, doctors are different, regions are different. And so, like I said, I think that, but in unusual cases like what Craig presented, I think those are ones where, you got to think a little bit that it's a little bit weird and maybe figure something out.
I think, I've been here now for 5 years, and I think, clearly that description of neurologists, nephrologists, even primary care physicians ordering SPEPs, I've seen that quite a bit. And actually how patients come to diagnosis sometimes is, they feel fine, they don't have any symptoms, but somebody did a test and that ended up showing a monoclonal protein. And that leads to a bone marrow biopsy referral to oncologist, and lo and behold, you get diagnosed with myeloma. So a lot of patients in my panel of transplanted patients, that is one of the ways they were diagnosed.
And while I would never, ever, ever refer a patient to a chiropractor, chiropractors are my favorite myeloma diagnosticians because they'll see a patient who be messing with their spine I don't think this is good, let's just get an MRI. Whereas the primary care physicians feels like, oh no, we can't possibly do it a CAT scan or MRI. It's going to take however long to finally do it. Chiropractors have no such compunction. They're like, hey, let's just get an image. And so half the time chiropractors can give me a diagnosis where these patients with osteoporotic compression fractures, this doesn't seem right. They just get an MRI right away. I love it because it gets the patient diagnosed quicker. So on average, I tell patients that the U.S. is a big place, and there are lots of geographic challenges. And you most likely did not choose your place to live based on whether you were close or far from somebody who did myeloma full time. So, I tell most of my patients that they should have one oncologist close to them and one oncologist that does myeloma full time. And that is what works out for the vast majority of patients who don't live next to an NCI comprehensive cancer center.